Good evening, everyone. Thank you for joining me this evening. I'm Professor Ying Cheong and would be soon starting this webinar as more participants log on. So just waiting for maybe a couple of seconds more and then we can start. So again, for those of you who have just logged on, good evening to you all. I'm Professor Ying Cheong. I'm the Medical Director for Complete Fertility, and I'm about to start a webinar on preparing for fertility treatment, just waiting for a couple more people to log on, and then we're off, we're ready to start. So I believe all of you would be aware of the Zoom function, the chat function, the Q&A function. I'm happy if you type any questions into these two functions, and I'll try to answer the questions that you have, usually at the end. But if I catch it, during the talk, I will do that. I'll try to answer them as best as I can. So I think I'm going to make a start now. We've got quite a number of attendees here now. So good evening, ladies and gentlemen. I'm Professor Ying Cheong. I'm Medical Director for Complete Fertility. And tonight I'm giving you a webinar on preparing for fertility treatment. And hopefully we're off to a good start. So what we're going to talk about tonight are really simple two areas that I will cover. Firstly, what happens during a fertility treatment, because that informs on what you need to prepare for. Then, of course, I'm happy to answer any questions in the chat, or as I say, Zoom also has a Q&A function. So please do type your questions in there. First of all, just a brief introduction. Who are we? We are a Complete Fertility Center here in Southampton, United Kingdom. But of course, we are part of a larger family of clinics worldwide. And you can see there, it spans literally globally. What are we aiming for our patients? Well, it's obvious to us and of course to yourselves, healthy singleton pregnancies. How do we achieve that? We achieve that through knowledge, skill, high quality, evidence-based, individualized care. We have a very active research program because we're affiliated to a UK large teaching hospital, and also we have clinics in the South Coast. I beg your pardon for my picture pasting skills. Some bits of the head has been chopped off. I need to remember next time to copy them properly. But they are a group of friendly, staff that we work with, looking after you and your care. And here are some of them. Now, your journey with your fertility journey varies depending on why you are coming to see your fertility doctor. Some would have come through the GP via NHS, whilst others would have been referred privately, or they would have referred themselves privately to us to be assessed. So our consultants, including myself, would be seeing your history, going through it in detail, and assessing what you next need. And then discuss some of these investigations with you before we proceed to any appropriate treatment. But this is really important, and I think very often, we're all very keen to jump to what can be done, but actually a lot of the medical diagnostic skill is in what investigations we do and how we interpret them and what we can then do to optimize your treatment. And sometimes some patients need further medical and surgical optimization, as you can see there on my flow chart. Now, what are the common causes of infertility? Well, there are numerous. Here I have some cartoons showing you, it could, of course, like the center bit here, fallopian tube problems. If the fallopian tubes or tube is blocked, clearly the sperm and egg would find it difficult to meet, and therefore results in, infertility. There's also an issue with egg quality being poor. Usually, not always, age-related. And if that's the case, it's important to realize that there are treatments that we can do to help. But of course, egg quality cannot be reversed. So the best thing to do is, of course, seek treatment in a timely manner so that we can help you have the best results. And of course, the ovulation problems. There are some patients where they ovulate very poorly, at the right time, not regularly. For example, women with PCOS or polycystic ovarian syndrome, you see that their ovulation is really poor and they don't ovulate regularly, and hence the infertility. There's also, of course, anatomical reasons for infertility, such as fibroid, which is a muscular tumor, not sinister, but it might impact on fertility and miscarriages, and then endometriosis, which is basically inflammation around the pelvis that can result in subfertility. Excuse me. Then, of course, as you can see, this fellow here, they're usually, very active, numerous in number, but if the quantity and the quality is reduced, you also have a problem. So apart from all this, the most annoying and frustrating diagnosis is unexplained. Now, there are many reasons why patients have unexplained subfertility. Now, to be honest, scientifically, there is most likely a reason, but current medical advances hasn't allowed us to be able to diagnose this, and therefore there is a diagnosis called unexplained. Whilst frustrating, it's important to realize this is totally treatable. You can see here in these nice little circles, I've summarized the possible treatment for various of these conditions. You will see that sometimes surgery is required, sometimes assisted conception, sometimes drugs. So it's very important that our consultants have a detailed history, an examination to ensure the right investigations and we get the right diagnosis. What do we mean by ovulation induction? As you can see on this cartoon, ovulation induction is one of the treatments that we can give patients. Most simple step, which is basically to give some tablets to overcome ovulation problem. Now, let me explain this cartoon. It's a very interesting cartoon about your biology. These are round things are the eggs, okay? And you can see here one little egg comes out, and this is a follicle that contains a little egg, yeah? As the egg comes out, it gets fertilized and it forms the embryo. Now, these little wiggly lines are hormones, okay? Now, the hormone levels are variable levels depending on your history, your medical condition, but some women, particularly those who need ovulation induction, they don't produce these ups and downs of these hormones that allows the eggs to be released, all right? So then what happens is then we can give simple medication to overcome this, to allow ovulation to occur, which then facilitate, of course, pregnancy. So this is the most basic and most simple treatment that we can give, but of course, not everybody benefits from it. For example, if you're ovulating already and your problem is a blocked fallopian tube, ovulation induction in any degree is not going to help. And hence, back to my emphasis that the diagnosis and investigations are very important. Now, secondly, there are also other types of fertility treatment or assisted conception treatment, such as intrauterine insemination, or in short, IUI. So the I, the uterine, I, insemination. And what happens there? You can see here the start line. There's 2 weeks, or roughly that duration of monitoring and allowing eggs to grow or follicles to grow in your ovaries. Now, can be facilitated by medication, but it may not need it. Depends on your individual situation. When the eggs are ready, we trigger it with a medication called HCG. And this, of course, also happens in your body normally, and that's how doctors know how to treat this, how to induce ovulation, which is to give this ovulation injection trigger. And then that releases the eggs. And what happens is, I know there's a donor sperm here, but there's obviously sperm, any sperm, really, sperm of their partner or donor sperm that could be then put into the uterus and facilitate ovulation, meeting the sperm meeting the egg, and therefore fertilization. Now, beyond that point, you have a further 2 weeks of what we call luteal phase, and that's the latter 2 weeks where you're waiting quite anxiously, of course, about with a pregnancy test looming, and then hopefully it's a positive for our patients, and you get a pregnancy scan at the end. So this is intrauterine insemination. Now, note that this treatment is not suitable for all patients because, of course, for example, if the sperm number or the fallopian tubes, if the sperm number is not enough or the fallopian tubes is damaged, then there's no way that the insemination process will work, right? Because the sperm cannot reach the egg. So this procedure is really more for patients who have a totally normal anatomy, totally open fallopian tube, totally normal sperm count, and also ability to ovulate, and there's no issues, and so on. So there are limitations to this treatment. Now, the prognosis, or rather the success rate of this treatment, also varies depending on the individual situation, anything ranging from something like under 5% to 20%, because the patients have different prognosis, and it totally depends on their medical condition, which of course our doctors can advise accordingly. This is a flow chart of what we call IVF treatment cycle. Again, IVF is not suitable for everybody, but at the end of the day, it is the most advanced treatment that can be given in terms of treating infertility. Why is that? Well, it's because we can give medication, as you can see here, injections that nurses would teach you how to do. We do a scan to check the egg and the ovaries, whether they're growing properly, and then we take the eggs out of the body, right? We take the eggs out of the body. So that means that we are bypassing problems that are associated with ovulation, problems that are associated with fallopian tube, and we're going straight to getting the eggs out of the body. And you can see here a really nice video, one of my favorites, embryo culture, where videos are taken, and this is happening every day in our laboratory, where the embryos are observed, fertilized, observed, and then you can see that they started from a few cells, and now there's a few hundred cells. This is in the incubator, and it's taken every couple of minutes, and these are blastocysts that looks really, really nice. And then these embryos are then replaced one at a time, because usually they're very good quality, but if they're not so good quality, then of course sometimes two are replaced, but of course that's something to be discussed at the time of treatment. Now, any spare embryos, of course, we're not going to throw them away. We put them in a cryopreservation system, where then They can be used in the future for baby number 2, 3, 4, and so on, depends on how many you want. But of course, some patients don't get the success in the first cycle, so then they will have the chance to have further embryos put back. But of course, frozen embryos are not available for everyone, so it's something that is, again, individual, right? And then beyond that, of course, we do our pregnancy tests with luteal phase support, like the previous process that I talked about. So that's a brief sort of nutshell of what these fertility treatments are about. But of course, the big question we have is how to prepare for this, you know? Okay, your consultant said, look, you know, you need this and you need that. How do you prepare? Or in fact, you're just trying. And then you're saying, okay, what should I do to optimize my chances of success, right? And then you look at your Google, and Dr. Google tells you so many things, and you think, oh my God, how do I know what to do? Okay, so I'm going to try to give you the answers here in the next couple of minutes. Now, it is important to optimize the body mass index. Now, a large proportion of our population in this country are now overweight, obese. Now, whilst many would have conceived anyway, our study has shown, and many others have also shown, that if the BMI or body mass index are high, and actually studies do show male and female do have impact, okay, but of course more studies are on female. Our studies certainly show if the BMI is very low, this is like really, really low, like under 19. Some women are quite have low BMI. Or if it's very high, it's associated with poor outcomes such as miscarriages. But of course, other studies have suggested it's associated also, of course, with infertility. Now, why? Well, because at these BMI, your body is in a sort of a preservation mode, so it doesn't ovulate properly. It is getting a message from you, oh, you're not ready yet for reproduction. And this is evolutionary signals, really. So it's important optimization of BMI, and it can be hard, certainly harder for some than others, but I have to emphasize that it's important. The second is smoking and alcohol. Now, smoking, time and time again, has been associated, both male and female, the poorer outcomes with regard to fertility. Right? Now, vaping has a less information about it, but ideally, of course, you don't want to be giving your body all the substance that is from nicotine and so on. So you'd want to quit it, really. Alcohol, now, of course, you know, the National Institute of Clinical Excellence, or NICE, has you know, advice on avoiding alcohol altogether. Now, I always say, look, you know, if you're going to take a little bit of alcohol now and again, it's not going to cause infertility, but you know, it is important that that little bit is not going to become half a bottle and then a bottle, because then that becomes that exceeds your limit, and then over time that's going to affect infertility. So it is about a sensible approach. But if you can, quit these habits. Folic acid, very basic advice, really, that your GP should normally give you anyway. But surprisingly, many women, when they come to us, they don't have this advice, or they're not taking this. So let me just quickly go through this. The folic acid is important because it prevents birth defects. It is proven time and time again. So this is really quite important, because the defects are what we call neurotube defects or spina bifida. And usually you're talking about 400 micrograms daily, which is normal dose. That is in all your supplements, which you're taking supplements, there's no problem. But if you have certain medical, and this is not an exhaustive list, certain medical requirements, then you need to go on a higher dose. Okay. Of course, greens, the nice vegetables that we all like, they have loads of folate, and that's really good for you. But if you're trying to conceive, these might not, or most likely not enough, and so a supplement is recommended. Vitamin D is really also very important. It is important for maternal and fetal aspects. So vitamin D is a vital component to regulate bones, teeth, muscles, and all sorts of biological processes in your body. So taking 10 milligrams, micrograms even of vitamin D each day is been advised. But don't take vitamin D from this supplement and then take another vitamin D from that supplement and then take another vitamin D from another supplement, because you can over-consume vitamin D. So be mindful that one supplement is enough as long as the dosage is recommended dosage. But of course, vitamin D is also in all sorts of food, oily fish, eggs, red meat. So, and in this country, the sun is not very strong, as we all know, and so it is important to make sure vitamin D is adequate level. Now, we have, of course, also conducted research in this area. My colleagues in research, together with myself, have looked at, vitamin D and omega-3, in oily fish, and looked at the outcome of embryos, looking at the outcome of follicular fluid, which is the fluid in the eggs. And of course, we have shown that having these supplements, which is really the typical Mediterranean dietary intervention, is actually does make a difference to the quality of the embryos and the follicular fluid, which is the fluid that nurtures the egg. Now, of course, none of these studies are, your sort of 1,000 women randomized control trials, but in our hands, we believe, and certainly in the University of Southampton, there's loads of work going on around vitamin D and omega-3 that supports the fact that these components are very, very important in preconceptually. Reduce caffeine intake. That's also something I find sometimes talking to patients. They actually don't know that 1 to 2 cups is the limit. They depending on the profession, sometimes their occupation allows them to sit down every couple of hours, get a cup of coffee, and they like strong coffee. At the end of the day, they've drunk 8 cups of coffee that are strong. So it's important, therefore, to put a little magnifying glass on your lifestyle just for a moment to look at these things, because of course caffeine intake have a data that is associated with pregnancy outcome that's poorer. Although having said that, to be fair, the data is somewhat controversial, but does suggest some dose-related effects. So I think, nothing is black and white most of the time in medicine. I think taking a sensible approach and having 1 to 2 cups is not a problem, but excessive dosage is to be avoided. And as you all know, metabolic rate is important to maintain a good active lifestyle, because metabolic disease such as diabetes, obesity, and so on has poor outcomes in terms of pregnancy. Now you say, oh, we've talked a lot about women, but what about men? What do we do? We can have a completely separate webinar on men, but I'll pick up the most important thing that we need to be highlighting, which is the sperm needs a lower temperature, not low, freezing low, right? A lower body temperature. So that's why the testes are outside the body, right? So it's important to avoid things like long duration of jacuzzi, which some of my patients really love and miss when I tell them you should avoid that. Hot baths and so on, but I don't mean you should be just putting yourself in cold showers. You have to be sensible about it, but it is important to realize that sperm do not fare well in high temperature. So wear loose clothing, avoid hot jacuzzis or long baths. That's generally what we would advice. I get asked this a lot. What do I do if I'm very stressed? How do I, does stress affect fertility? Now, it's very difficult to measure stress, okay? But I would say to most patients, try to manage stress because, of course, fertility treatment is stressful enough. You don't need to start treatment with a stressful life already. So I think some of the stress management strategies here is not exhaustive, but everybody finds their own way of managing their stress. And of course, in our fertility center, counseling is available freely. And so patients can access that also if they feel they need to talk to a counselor about various things that is concerning them. But there is no stress measure as such, but it is important to, I think, help you manage the fertility treatment journey. What about all the other supplements that perhaps are in your drawers and in your cabinets currently? Or perhaps you look at the shops and have all that. Well, I mean, can spend a whole day talking about each supplement on its own. But at the end of the day, there's no magic supplement. What's important is a balanced diet. Okay, so it's really important that you look at your portions, you look at your carbohydrate intake, your glucose intake, and make a sensible adjustment for that. And loads of greens and antioxidants in fresh fruits and berries and so on. They're also highly recommended for men and of course also for women. So whilst you may have a few supplements in your cupboard, just make sure that they're not harmful, they're non-toxic, which I hope they're not. But at the end of the day, it's about a balanced diet. Now, what about complementary and alternative treatments? So I got asked a lot. And I did help with HFEA's publication a couple of years back now, where they had a piece around sort of what to write on their website. You can go to the website to look at it. We have also done some studies on acupuncture and so on. At the end of the day, I think it's whatever that makes you more relaxed and feel generally well. The medical effect of acupuncture and complementary therapy is not really easily measured in our current way of studying fertility outcomes. So I would say if you feel it's making you relax and you're not taking extra drugs or things that you don't know where it's coming from, then by all means, go for these, because anything that makes you relax and generally feel well must have a positive effect on you going through the fertility journey. And of course, most importantly, I can't stress it more, is that at the end of the day, it's about you seeking the right medical help. And at Complete Fertility, we offer that. And our doctors, consultants will look through your history and talk through things with you. Because different patients have different expectations and they have different wishes, different circumstances. And so looking at each of you individually will give us a clue about what's the best journey for you. And so a timely advice, albeit it could be reassuring sometimes, nothing more. I find over the years, patients really benefit from it. So get the right medical help, as soon as you feel you need it. And we will be able to then advise you to say, don't worry, you get there. Or we can say, look, I think you need this, that medical treatment. All right. Now, our fertility center is doing an open evening tomorrow. If you fancy popping down to Princess Anne Hospital in Southampton, if the registration is not already full, I have to say, but there will be other open evenings. So, you know, you can, of course, register on those then if it's full. But we welcome you to participate in our open evening. So with that said, I'd be very happy to get questions from you now. If you have any questions for me, please type it into the chat or the Q&A, and I will spend the rest of the time here trying to answer the questions that you have. I'll just have a look at the chat. Sorry, I just need to open the webinar chat box to make sure that we've got that. There we are. So yeah, so just type it. Just type your questions in there. So I have some questions here now on treatment. Are treatments other than IVF, example drugs and IVF, available on the NHS? That's a good question. So at the moment, IUI is not available. Certainly ovulation and induction, yes, on the NHS, if the right medical condition is diagnosed. IVF, yes, only if you fit into a certain eligibility criteria. So now, for example, in Hampshire, in the Southampton area, the eligibility criteria will be if the woman for treatments under 35, if they are non-smoker, the woman and men are both non-smokers, if the woman's BMI is under 30, they have no children, and never had any sterilization procedure, obviously. And if you go to Dorset, their age criteria is again different. They go up to 40, I think, or 42. Or, anyway, it's not 35. You know, they go up to 40, and they're found one cycle, and they are smoking again, same, no smoking. But BMI pertains to both male and female to be under 30. I can go on. You know, there are very specific, and that's why it's called postcode lottery, which I don't, you know, it's not today's topic to discuss, but it's certainly different for each region. So they are available, but there are criteria which will have to be satisfied. And also it depends on which area, region you're coming from. And also it depends on whether you know you're military and so on. So that there are various different criteria. But the best thing to do is get your fertility assessed and then discuss some of these areas which potentially you might find very difficult to get generically from your GP. You could go through that on the NHS appointment if it's available to you, or you can go down the private route just to get these clarified. That's not a problem. We have quite a number of questions, so I'll move on. If you're lucky to have optimal conditions, how long would a typical IVF cycle take? Well, apologies, I didn't mention that earlier, but the IVF cycle generally takes 2 weeks of stimulation and 2 weeks so the luteal phase support and waiting for the results. So a month and thereabouts, you get that in terms of starting and knowing what the results are. Okay. So it's quite quick. So it's and some people have described the IVF's journey as like a roller coaster. You can imagine, right? It's nothing. You're waiting, you're getting investigated, and then suddenly it just starts, and in a month it finishes, right? And then you have a pregnancy test, positive or negative, and then you have to discuss what's next. So it is quite fast. Can supplements such as Pregnacare affect your period? I don't think there is evidence to suggest that. So if you find that your periods are slightly odd, or they're not coming, regularly, then there may be an ovulation issue rather than relating to supplement as such. There's another question here. Does IUI treatment have to be paid for in one payment or paid before each stage at the process progresses? Yeah. So this arena has had a lot of assistance from payment plans around that have been around now for a few years. So if you were to undertake treatment with your own funding, no payment plan, whatever, then yes, you will need to have payment upfront. But if you're doing a payment plan, then of course you deal with the payment plan company, which it will not be our fertility center. And they will then, of course, get you installments or whatever. So it's worth looking at our website, www.completefertility.co.uk, and you will see some on there. If you search payment plan, it'll come out. So it's important to realize that there are some assistance for treatment that is available, and each person will have a condition that is different. So you might need a different payment plan depending on what you want. But patients have found that very useful. I've got a question here. Me and my partner have been trying for almost a year. We have had fertility tests, and he had plenty of mobile sperm, plenty of eggs, and clear tubes. What would you suggest as our next step? It's very interesting, this question, because it suggests, and of course I need to look at the other test results, which you haven't spelled out. I need a more comprehensive review of your results. But if indeed all the investigations were normal, which as I explained earlier in the very first few slides, that there is a condition called unexplained infertility. Now, it is frustrating because you think, what's going on? Why is it not happening, right? And as I say, there probably is something, but our test is not sensitive enough to pick it up at the moment. Maybe in 5 years, 10 years time, but not now. So then the answer to that question boils down to the fact of that what do you as a couple want to do? Now, clinically, after 1 year of trying regularly with everything is normal, then it means by definition infertility, which means you should be accessing some fertility help. And if all the investigations are normal, means perhaps then the next step usually is IVF, usually. But as I say, I haven't seen all your results because the hormone tests and all those things. So we will need to review those with a fine detail before we can really recommend or advise. But I hope I cover the rough remit of what I think you're trying to ask. Okay, the next question, how long on average is the waiting list for IVF? Maybe an important, yeah. Yes, it is quite an impossible question, but I'm thinking that if you're asking, okay, if you come tomorrow and you say, oh, your doctor says you need IVF, how long do you need to wait? Now, it depends on whether you're coming through as a private patient or as an NHS patient. The private patients tend to have not a lot of wait. Now, the NHS patients in general, not until recently, right, has not, again, not a lot of wait, but due to financial resources issues with that, I suspect the wait is going to get longer and longer. So perhaps a few months for the NHS, maybe even longer, depending on what's going to pan out, in the near future. But the private patients would have you have your investigations. You can have treatment next month if you want. Yeah, I know there's a disparity. We would have loved to just have had no difference, but the funding resource restrictions from the NHS side is a problem. How long can it take to get a referral from a GP to your services? Yeah, that's also another area which I think patients find over the years. I know that the patients find it very frustrating. It varies so much. In my experience, GPs, some GPs refer really promptly, and there's no issue at all. They just do all the preliminary tests, they send the patients, and we see them very quickly. But others struggle. It can vary from a month, 6 weeks, 8 weeks, 2 months. And I can't really tell you why. Yeah, I can't explain what the variation is down to, but the experience from when we get first contact with our patients, that's generally, you know, the time frame that can be very variable. So I'm afraid it really depends on the GP. But as I say, you can go down the initial private route just to find out information, because sometimes information helps with reassurance, you know, and sometimes that's all you need. And you can do that, and our doctors will see you and explain things to you. But of course, if we find something and you need treatment, and at least you know that earlier, right? Next question, how does it work if a single female, you want to have a baby, not known fertility problems, previous baby successful, but also want to donate your eggs at the same time? Will there always be enough eggs for you in case you need to try more than once? Okay, this is about egg donation, and so we have a very robust donation team, and egg donation is certainly you know, a very altruistic in contribution, you know, and we would advise you accordingly as to whether you're suitable to donate your eggs or even share it for your treatment. But there are medical criteria that we have to look at to then be able to advise you. Some women will be able to donate and have treatment themselves, and some won't, because maybe their egg numbers are not enough, or there are other medical conditions. So for this question, I would advise that perhaps you contact our fertility center, explain the situation, they'll tell you what the next steps are. Usually it will be a consultation with one of our doctors first. I hope that answers your question, but it is a very altruistic sort of thing to do, so thank you for thinking about that. How long is the waiting list once the GP referred us to the fertility clinic? Yeah, this is the same question as the previous one. So when the GP referred to us, it doesn't mean we get a referral. There is a sort of a gray zone, which I can't really explain to you why is that, right? But if once we receive that referral, then of course we can then arrange the appointment. Usually that occurs in 6, 8 weeks. If the worst case scenario, a little bit longer, but the best case scenario even shorter. So, but the GP referring to us doesn't mean we get the referral. It's about us getting the referral. That is, you know, all in our hands. Then that's where we have the control. So unfortunately, I won't be able to tell you what the GP referred to us, that sort of gray zone. What is that duration? I don't know, right? So as I say, some GPs take longer, and some GPs are shorter. But I still yet to get to the bottom of why that's the case. So if you have an issue, of course, you can go down the sort of private consultation route, just to understand what's happening first, even if it's just one consultation, because then that sets peace of mind. But if you want to inquire with our fertility center, also you can, because then they can tell you whether we've received the fertility referral or not. how many chances of an embryo transfer do you get in one round IVF? Is there 2 each transfer? Yeah, that's a very good question, actually. And the answer is it's very variable depending on your postcode. Right? Is that surprising? Right. If it's NHS cycle, okay. Now, if it's but in any cycle, right? What is the chances of anybody getting an embryo to freeze? Okay, so there are a few interpretation of your question is slightly. So I'll try my best to answer. So the first question I come to mind that I interpret this question is, in a one cycle IVF, how many embryos do you generate so that you can use future embryos for with frozen embryos, right? Now it varies depending on how many eggs you have, and therefore age dependent. The younger patients with good egg reserve, which is a test that we can do, we would expect that your egg quality better, then you have more embryos, and therefore you have one embryo transfer, and then you have more embryos that are frozen, maybe 2, maybe 1, maybe 3. I've seen patients with 6 embryos that are frozen there. Okay. But if the question is around, if you're going to have an IVF cycle on the NHS, how many embryo transfers are you allowed? Completely different depending on which region you are from and what was the approval what did they approve. If they say, oh, you only have 1 fresh cycle, that's it. If they say 1 fresh and 1 frozen, and then 1 fresh and 1 frozen, okay. So it's not about 3 chances, 2 chances, 1 chances. The first thing is how many embryos have you created, and the second thing is because if you have good embryos created, plenty of them, then you are likely to have those extra ones stored. But if you are asking about how many cycles like NHS fund, then it's variable, and that will come when you apply for the funding. The embryo numbers depend on age, and the better quality eggs with younger women are more likely to have more eggs, but it's not always, right? Some older ladies also have a good reserve. So it really depends on the test results, the number of eggs, number of embryos we create. Okay. I hope that answers your question. If you have had 3 rounds of Clomid, can you then decide to try IVF rather than continue Clomid? Yeah, of course. But generally speaking, we advise 6 cycles because that's the top limit of Clomid treatment. Clomid is basically a medication for ovulation induction, for those of you who don't know what Clomid is. And generally speaking, we say, okay, make use of the 6 cycles. But if your Clomid treatment wasn't working, even after the 3rd round, you keep increasing the dose and nothing happens, there's no point carrying on. Then you might as well move on to IVF. Yes, all right. So it really depends on medical condition, and that and so we need to look at it closely for you. The next question is, if you are a same-sex female couple looking to undertake IVF, will you need to undertake the same investigations before the IVF treatment? Yes, generally speaking, yes. We would expect that, but there are some exceptions. Okay, so but generally speaking, we do need to work out the hormones are all right and the various different things are all right. But there's certain investigations potentially we can discuss, perhaps not needing to do it because there's differences in terms of a same-sex couple versus a heterosexual couple. But that's certainly something we can discuss with you at a consultation. But the blood tests, generally speaking, are the same. Ultrasound and so on, they are the same, right? So we can advise you accordingly if you need to. The next question, me and my husband, we were over 30 years old. We have a daughter, 9 years old, also in 2015. I was pregnant, but unlucky we lost the baby. Since then, we are trying, but nothing yet. With many meetings with doctors and many different checks. But what's the chances to get pregnant again? Thank you. Okay, so assume you're just over 30, you're over 30, and you've had 1 child before. So, actually that is a good sign because you've had
unknown caller.
You had a pregnancy, sorry about that. You had a pregnancy before, so that's a good sign. Hello? Yeah, sorry. Sorry about this. Someone's on my mobile phone. You just know it when you're doing a webinar, there is a phone call. Apologies for that. So yeah, so there's good prognosis for you. The couple was asking about their prognosis since they've had a pregnancy, but it's important that if you're going to come to us and tell us your history, we will be looking at your history, saying, okay, what's happened between 2015 and now? Okay, yeah, and are there any other reasons why these things are happening? Okay, so there are certain tests that we will be advising so that we can get down to the nitty-gritty of are there any other reasons why things are not happening? Because you've had it before, it was no problem. So what's wrong now, right? So this is what we call secondary infertility. It's slightly different from primary infertility, where no previous birth, right? Secondary, and there are different reasons why some couples end up with secondary infertility, and that's really important that we do the right investigations for you so that we can give you the idea of what the chance of getting pregnant again is, right? I wish I could tell you exactly what the chances are again now, but with the information you put on the chat, it's not enough. So I would suggest, if that's really bugging you, that you get either a referral from a GP or come to our fertility checkups, and we can then advise you on that. We do a fertility checkup in our fertility center, and that includes a scan and blood tests and so on. And that a history, and that will give us hopefully shed some light on your problem. Okay. The next question is there a BMI limit for IVF if going private? Our BMI limit is 35, which is higher than the NHS, because we realize that actually there are certain conditions where women find it very difficult to shed the BMI. But 35, anything above 35, we would encourage patients to lose the weight because of the effects that I mentioned earlier about in our studies and many other studies in the literature about fertility and the impact of BMI. The next question is, does PCOS mean my quality of eggs will be bad? No, Katie, that's not true. It's not, PCOS doesn't mean poor eggs. PCOS just means the ovaries are full of little eggs. They're not sinister, they're not cancer, but the problem with that is they don't normally allow the ovaries to ovulate the eggs easily. So if you don't ovulate the eggs, means that what happens? The sperm can't meet the egg, and therefore no pregnancy, right? So so there are medications that we may have to give and so on, but it doesn't mean that the quality of eggs is bad. And in fact, many women with PCOS we never see, because they conceive and they have a family. We never see them. So don't think that you have poor eggs, huh? Next question is, me and my wife looking into IUI treatment. Should be the one who carries the baby and knows she will need the test. As I'm not going to be contributing, do I still need to do the test? Assuming, yeah, so I know from the name, assuming this is a same-sex relationship, no. So no, so it's the carrying partner who then needs the investigations. But of course, we just always do a health assessment from a history to make sure that your health is also okay. But no, not the same investigations. Next question, we've got a few more, so I'm going to talk a bit quicker. I'm so sorry. Private patient, how many chances do you get in one round IVF? Is it just determined on how many embryos that are formed via ICSI to how many chances you get? So say 5 embryos, first embryo transfer but failed. Will I get the chance to have all the 5 embryo transfer before paying for another round? No, good question. So the fresh round IVF is 1 cycle and the frozen embryo transfer is another cycle. But the frozen embryo transfer is the pricing is a lot cheaper than the fresh cycle. So a good IVF cycle would be, for example, in terms of cost, one that created a few embryos so that you can use one and you either successful, come back for child number 2, 3, 4, or you don't succeed and you have more in the freezer, and then you go for what we call frozen embryo transfer, and that's a separate cost, but the cost is lower, much lower. And also the treatment cycle is much easier. So there's no stimulation of eggs, no need to collect eggs and all that. Yeah. Next question is surgery the first choice patient who have varicocele? Not really, not always, but we would advise that you get the varicocele investigated by our andrology urologist, which we have also in our center, and get that assessed, because the varicocele not always need treatment, but a urology andrology opinion would be important because different patient has different types of varicocele. Next question, can I be an egg donor if I have PCOS? Under our clinic criteria, unfortunately, no. So a reason is because patients with PCOS, their stimulation cycles can sometimes be a bit tricky. They produce sometimes too many eggs, and it's very difficult to control their simulation, so that so we're very cautious about it. And of course, PCOS is always a known medical condition, so we avoid having egg donors with PCOS because of the risk of the treatment cycle if they become an egg donor. The next, but of course, no risk if you're going to have your treatment yourself. It's just when you're undergoing donation treatment. I hope that's clear. Yeah. Through IVF, is there only ever one embryo inserted, or sometimes more than one? Yeah. Usually one. If it's good embryo, we advise one embryo replace, because ultimately you want one healthy baby. Because it's not about the pregnancy test or the number of embryos or whatever. At the end of the day, you want that healthy baby, right? That's delivered. Yeah. So one embryo gives you the best chance if the embryo is of top quality. But as I explained earlier, there are certain conditions where we accept there may be a risk of twins, but we accept that, okay, the quality may be not as good, or the age of the woman is not is higher than we than use 2. But in the UK, 2 is the max. We don't go above that. Okay. Whilst there's a lot of questions around, what if we want twins and so on. Twin pregnancies are a riskier pregnancy, and sometimes, if you put 2 very good embryos in, it will most likely discount the chance of you getting a one healthy baby, because miscarriage rate would be higher. Early birth, premature birth is not about a week or 2 earlier. You're talking about the very, very small babies that are in hospital for weeks or months. Now, if you undertake fertility treatment, the last thing you want to do is have that occur to you. So we do always say one embryo, healthy baby at the end. That's what we're aiming for our patients, but there's certain flexibility in some patients depending on the condition. So that's certainly something that we discuss with them. Our patients, regularly. So I think, feels like a marathon, but I think I've managed to finish all the questions. So I hope you find this useful, and I'll now have to close this webinar. I hope you find this useful, and if you can make it to our opening thing, please register. Right. Have a good evening. Take care now, everyone. Bye-bye.